Disclaimer: this podcast is for informational and educational purposes only. It is not medical advice, diagnosis, or treatment. Always consult a qualified healthcare professional before starting or changing any therapy, supplement, or peptide protocol. Welcome to the Peptide Effect. In today's episode, we're diving deep into the differences between GLP-1, GLP-2, and Retatrutide, three peptides that have been making major headlines in the metabolic and peptide science world. They might sound similar, but they work in very different ways. So today, we're going to unpack what each of them does inside the body, how they affect metabolism, how they're dosed, and what makes Retatrutide the next big evolution in this peptide class. Let's start with GLP-1, short for glucagon-like peptide 1. GLP-1 is a naturally occurring hormone produced in your intestines, mostly by what are called L cells in the distal small intestine and colon. It's released after you eat, especially in response to carbohydrates and fats. The main job of GLP-1 is to help regulate blood sugar by stimulating insulin secretion when glucose levels rise. It also suppresses glucagon, the hormone that increases blood sugar, and it slows down how quickly your stomach empties. The combination of these effects keeps your glucose level steady, reduces hunger, and promotes satiety, or that feeling of being full. Now, in peptide therapy, synthetic GLP-1 agonists have been created to mimic that natural effect, but in a stronger and longer-lasting way. Some of the most well-known GLP-1 analogs are semaglutide, liraglutide, dulaglutide, and exenatide. You might recognize them by brand names like Ozempic, Wegovy, Victoza, Trulicity, and Byetta. Each of these medications binds to the same GLP-1 receptor, but they differ in structure, duration of action, and potency. Mechanistically, here's what happens. When a GLP-1 analog binds to the receptor, it activates a cascade that increases cyclic AMP levels inside pancreatic beta cells. That leads to enhanced insulin secretion, but only when blood glucose levels are elevated. This is key because it means GLP-1 doesn't cause low blood sugar on its own the way insulin injections sometimes can. It's glucose dependent. It also acts on the hypothalamus in the brain to reduce appetite, on the gut to delay gastric emptying, and on the cardiovascular system where it may have protective effects like lowering blood pressure and reducing inflammation. Now let's talk dosing because that's where these analogs really differ. Semaglutide, for instance, is typically started at 0.25 milligrams once weekly, then gradually increased over several weeks up to a maintenance dose of 1 milligram or even 2.4 milligrams depending on the formulation. Liraglutide is usually dosed daily, starting at 0.6 milligrams subcutaneously, increasing to 1.8 milligrams for diabetes or up to 3 milligrams for weight management. Dulaglutide is another weekly injection, with doses ranging from 0.75 to 4.5 milligrams. The goal with all of them is to build tolerance slowly, because side effects like nausea, bloating, and delayed digestion are common early on. It's not that the peptide is dangerous, it's that the body is adjusting to slower gastric emptying and stronger satiety signaling. That's why starting low and increasing gradually matters so much. Clinically, GLP-1 agonists are used for type 2 diabetes, obesity, metabolic syndrome, and even cardiovascular risk reduction. They've shown benefits beyond blood sugar control, including weight loss, lower cholesterol, improved blood pressure, and possible neuroprotective effects in conditions like Alzheimer's and Parkinson's disease. But they're not perfect. The most common side effects are gastrointestinal, nausea, vomiting, constipation, or diarrhea. These usually lessen over time. Rare but serious risks include pancreatitis and gallbladder issues. There's also a theoretical risk of medullary thyroid carcinoma, which is why these drugs carry a warning for people with a personal or family history of that rare cancer. In terms of half-life, GLP-1 analogs range widely. Exenatide, the first-generation analog, lasts about 2-4 hours, so it requires twice-daily dosing. Liraglutide lasts around 13 hours, which allows for once-daily dosing. Semaglutide lasts around 160 hours, or roughly 7 days, which makes it convenient for weekly injections. Dulaglutide has a similar weekly profile. The longer half-lives not only improve convenience, but also create a more stable plasma level, leading to smoother appetite control and less fluctuation in effects. Now, mechanistically, the benefits of GLP-1 go beyond blood sugar and appetite. In the liver, GLP-1 helps reduce fat accumulation. In muscle tissue, it can enhance glucose uptake. In the heart, it improves endothelial function and may reduce inflammation. In the brain, it influences reward centers that control cravings, which is one reason people on GLP-1 agonists often report reduced desire for high-calorie foods or alcohol. Let's pause for a second here. When you think about GLP-1, the key points are: it helps regulate glucose, suppresses appetite, slows digestion, and may improve overall metabolic efficiency. It's a multifaceted peptide that's revolutionized weight loss and metabolic health therapies. Now, let's start transitioning toward GLP-2 because even though the name sounds almost identical, the functions are quite different. GLP-2 stands for glucagon-like peptide 2. It's also secreted by the intestinal L cells, often alongside GLP-1, but it binds to its own unique receptor, the GLP-2 receptor, found primarily in the gut and the central nervous system. While GLP-1 focuses on blood sugar and appetite, GLP-2's main role is gut growth, nutrient absorption, and intestinal repair. In other words, if GLP-1 is about regulating metabolism, GLP-2 is about strengthening the gut itself. Mechanistically, GLP-2 works by stimulating intestinal epithelial growth and reducing cell death in the mucosal lining. It increases villus height, expands the absorptive surface area, and enhances nutrient uptake. It also increases blood flow to the intestines and reduces gut permeability. That makes it incredibly important for anyone dealing with intestinal damage, inflammatory bowel conditions, or short bowel syndrome. The main synthetic GLP-2 analog used clinically is teduglutide, marketed as Gattex. Teduglutide is almost identical to natural GLP-2, except for a small amino acid substitution that makes it resistant to degradation by the DPP for enzyme, the same enzyme that breaks down natural GLP-1. Because of that modification, teduglutide has a half-life of about 2 hours compared to natural GLP-2's 7 minutes. That's a big difference. Teduglutide is administered subcutaneously once daily at a typical dose of 0.05 milligrams per kilogram of body weight. Its primary indication is for short bowel syndrome, a condition where a person's intestines can't absorb nutrients properly because large portions have been removed or damaged. By promoting mucosal growth, GLP-2 helps restore absorption capacity. But here's where it gets interesting. Researchers have started looking at GLP-2 beyond gut repair, especially its role in gut-brain signaling and systemic inflammation. Because the gut is the largest immune organ in the body, improving intestinal barrier integrity through GLP-2 may reduce systemic inflammation and improve metabolic health indirectly. Some data even suggest potential applications in leaky gut syndrome, Crohn's disease, and ulcerative colitis. However, GLP-2 is not primarily a metabolic peptide in the way GLP-1 or Retatrutide are. It won't cause appetite suppression or major fat loss. Its benefits are more structural and protective. When comparing GLP-1 and GLP-2, the key difference is where they act. GLP-1 acts on the pancreas, brain, and stomach to regulate insulin and hunger. GLP-2 acts mainly on the intestines to promote growth, absorption, and repair. GLP-1 influences energy balance, while GLP-2 supports nutrient handling and gut integrity. That said, both share some overlap. Both are secreted after eating, both are degraded by the DPP for enzyme, and both are part of the body's natural way of maintaining metabolic balance. One helps the system absorb nutrients efficiently, the other helps use them effectively. Next, we're going to get into Retatrutide, which is where things get really fascinating because Retatrutide doesn't just act on one receptor or even two. It's a triple agonist. And that triple mechanism might make it one of the most powerful metabolic peptides ever developed. But before we move on, here's a quick recap of what we've covered so far. GLP-1 is the peptide that helps regulate glucose and appetite. It's what medications like Ozempic, Wegovy, Victoza, and Trulicity are based on. GLP-2, on the other hand, is about gut healing and nutrient absorption, best represented by teduglutide or Gattex. They share a similar origin in the body, but serve completely different roles once released. Alright, let's move into Retatrutide. This is where peptide research is heading right now. Retatrutide is what's called a triple agonist peptide, meaning it acts on three different receptors: the GLP-1 receptor, the GIP receptor, and the glucagon receptor. If you think of GLP-1 as a one-receptor player, Retatrutide is a full orchestra. The GIP receptor stands for glucose-dependent insulinotropic polypeptide receptor. Like GLP-1, GIP helps regulate insulin release, but it's secreted earlier in the digestive process, mainly by K cells in the upper small intestine. On its own, GIP doesn't have huge metabolic benefits. But when combined with GLP-1 activation, it creates a synergistic effect that enhances both insulin secretion and satiety. Then comes the glucagon receptor, the third target of Retatrutide. Normally, glucagon raises blood sugar by signaling the liver to release glucose. But when you combine controlled glucagon receptor stimulation with GLP-1 and GIP activity, you get a paradoxical metabolic boost, increased energy expenditure, and fat oxidation without dangerous hyperglycemia. Essentially, Retatrutide turns on all three metabolic levers at once, more efficient glucose use, reduced appetite, and higher calorie burn. In early studies, participants using Retatrutide lost significantly more weight than those on semaglutide alone, in some cases approaching 24% of total body weight over 48 weeks. That's an enormous effect size compared to any previous single agonist peptide. In terms of dosing, Retatrutide has been tested in weekly subcutaneous injections ranging from 1 to 12 milligrams. Like other GLP-based agonists, it requires a slow titration to reduce gastrointestinal side effects. Because it's still in clinical trials, there's no commercially available product yet, but the data so far show a half-life of around 6 to 8 days, meaning once-weekly dosing is feasible. Mechanistically, the triple agonism means Retatrutide hits metabolic pathways from multiple angles. GLP-1 and GIP improve insulin response and reduce appetite, while the glucagon component boosts resting energy expenditure. Together, this combination promotes a shift toward fat loss while preserving lean mass better than GLP-1 alone. So now that we've laid out the basics of what GLP-1, GLP-2, and Retatrutide actually are, let's dig into how they stack up against each other in real-world use, and what those mechanisms mean for the results people actually feel. Let's start with Retatrutide and GLP-1 because those two are the most similar in purpose. Both are metabolic peptides aimed at glucose control and weight management. With GLP-1 agonists like semaglutide or liraglutide, the main driver of weight loss is reduced appetite and slower gastric emptying. People eat less, feel full longer, and often change the way they think about food. You can literally see the difference in brain imaging studies. The reward centers light up less when shown pictures of high-calorie food after GLP-1 treatment. It's not willpower, it's chemistry. But with Retatrutide, there's an extra layer. Because it also activates the glucagon receptor, energy expenditure actually goes up. In other words, you're burning more calories even at rest. It's one thing to reduce intake, it's another to increase output, and Retatrutide does both. That's why the weight loss numbers are so high. Now, let's talk numbers for context. In major semaglutide studies, participants lost around 15% of their total body weight at higher doses. That's impressive. It's enough to reverse diabetes for many people. Retatrutide, in early trials, produced up to 24% weight loss at the highest dose. That's approaching the kind of results seen after bariatric surgery, but with a weekly injection instead of an operation. Mechanistically, this happens because glucagon receptor activation stimulates brown adipose tissue thermogenesis. Basically, your body produces more heat and burns fat for energy. It also slightly increases resting heart rate, which is one reason heart rate monitoring is being studied closely in long-term trials. Now, when comparing these two, the side effect profiles are also slightly different. GLP-1 agonists tend to cause nausea, especially in the first few weeks. Retatrutide does too, but it may also cause more pronounced increases in heart rate or mild jitteriness in some people due to the glucagon effect. The good news is that, like most peptides, the body tends to adapt as the receptors normalize and the gastrointestinal tract slows down. One important question people often ask is, if Retatrutide works on GLP-1 receptors too, can you combine it with another GLP-1 agonist like semaglutide? The short answer is no, not safely or logically. They act on the same receptor systems, and stacking them could amplify side effects without adding real benefit. The power of Retatrutide comes from its triple receptor design, not from stacking multiple drugs. Now, let's swing back to GLP-2 for a minute. Unlike GLP-1 or Retatrutide, GLP-2 doesn't target metabolism directly. So, if you were thinking about using it for fat loss, it's not the right tool for that. However, in the context of gut repair or inflammation, it can be very powerful. For instance, after long-term GLP-1 use, some people experience mild changes in digestion or nutrient absorption. That's where GLP-2's protective effects could theoretically support intestinal health. To visualize the difference, GLP-1 controls how much food you eat and how fast it moves through you. GLP-2 controls how well your body absorbs and uses the nutrients from that food. Retatrutide takes the GLP-1 mechanism and adds a metabolic accelerator on top. Let's compare receptor distribution, because this is where everything starts to make sense. The GLP-1 receptor is found in the pancreas, brain, heart, and stomach. The GLP-2 receptor is almost exclusively in the gut. The glucagon receptor is mainly in the liver, with smaller amounts in fat tissue and the brain. The GIP receptor is in pancreatic beta cells and adipose tissue. Retatrutide hits all three of those, so it's not just one signal, it's a full system reset on how the body handles fuel. Next, let's talk about dosing frequency and duration of action. GLP-1 analogs like semaglutide and dulaglutide are once weekly, liraglutide is daily, and exenatide can be either twice daily or once weekly depending on formulation. GLP-2 analogs like teduglutide are once daily. Retatrutide, based on its long half-life, is once weekly. So in terms of convenience, Retatrutide matches the newest GLP-1 drugs. All three are administered subcutaneously, typically in the abdomen or thigh. They should be injected at consistent times of day, and for peptides with weekly dosing, consistency on the same day each week matters to maintain steady serum levels. Another important difference is receptor tolerance. GLP-1 receptors can downregulate with chronic exposure, which is why some people plateau in their results after several months. Retatrutide may have less of that issue because it distributes activity across multiple receptor systems, but since it's still being studied, that's not fully proven yet. Now, let's touch on what happens inside the body after injection. GLP-1 agonists start lowering blood glucose within hours and reach steady state within 4 to 5 weeks. Appetite suppression usually appears within the first week. For GLP-2 analogs, intestinal blood flow and villus growth increase over days to weeks. Retatrutide behaves more like semaglutide, steady onset, gradual appetite suppression, and sustained energy expenditure once plasma levels stabilize. If you were to map the curve of effect over time, GLP-1 starts strong and then plateaus as the body adapts. GLP-2 builds gradually and stays steady. Retatrutide continues to ramp up longer because of its multi-pathway engagement. Let's take a moment to talk about lean body mass, because that's one area where GLP-1 agonists can struggle. When people lose weight quickly through appetite suppression alone, some of that loss comes from lean muscle mass. That's why you'll hear clinicians recommend pairing GLP-1 one therapy with resistance training and adequate protein. Retatrutide, in early data, appears to preserve lean mass better, likely because of the glucagon component increasing energy expenditure and potentially promoting lipolysis rather than pure caloric deficit. Now, let's look at cardiovascular effects. Both GLP-1 and retatrutide have positive impacts on lipid profiles, blood pressure, and inflammation markers. GLP-1 agonists like semaglutide have proven reductions in major adverse cardiac events in large trials. Retatrutide is expected to share those benefits, though long-term studies are ongoing. GLP-2 doesn't really affect cardiovascular outcomes directly, but by improving gut barrier integrity, it may have downstream benefits for systemic inflammation, which can affect heart health indirectly. Something else worth mentioning is how these peptides influence the brain. GLP-1 agonists cross the blood-brain barrier and act on the hypothalamus, reducing hunger and cravings. GLP-2's brain effects are more subtle, focused on neuroprotection and possibly mood regulation through the gut-brain axis. Retatrutide, through its GLP-1 and GIP components, has strong central appetite effects, which is why the desire for food can nearly vanish for some people once fully titrated. One area that's emerging in peptide research is neurodegeneration. GLP-1 agonists have shown early promise in Alzheimer's and Parkinson's disease because of their anti-inflammatory and mitochondrial effects. Whether retatrutide could extend those benefits is unknown, but given its mechanism overlap, it's very possible. GLP-2 may also support brain health indirectly by reducing systemic inflammation from a healthier gut. Let's talk a bit about the way these peptides are metabolized and cleared. GLP-1 and GLP-2 are both rapidly degraded by the DPP for enzyme, which is why analogs are chemically modified to resist breakdown. Retatrutide is engineered the same way, using specific amino acid substitutions and acylation to bind albumin, extending its half-life. That's why you get week-long activity from a single injection. In clinical practice, the titration schedule for these peptides is crucial. You never start at full strength. For example, semaglutide begins at a quarter dose, then doubles every 4 weeks until the maintenance level is reached. Retatrutide would likely follow a similar model once approved. This helps minimize nausea, bloating, and early appetite suppression that can make it difficult for people to maintain proper nutrition during adaptation. Now, something that often gets overlooked is how these peptides interact with lifestyle. GLP-1 agonists and retatrutide can blunt hunger so strongly that people accidentally undereat or miss meals, leading to fatigue or muscle loss. So, even though the appetite suppression is helpful for weight management, it's still important to maintain protein intake, hydration, and resistance exercise. There's also the psychological side. Many users describe a reduction in food noise, that constant mental chatter about eating. This is one of the most transformative effects, and it's primarily a result of GLP-1 receptor activation in the hypothalamus and brainstem. Retatrutide amplifies that effect through GIP synergy. Let's compare safety profiles a little more carefully. For GLP-1 analogs, we know the big 3 side effects: nausea, constipation, and fatigue, especially early on. Gallbladder issues and mild elevations in pancreatic enzymes can occur. For GLP-2 analogs, The main concerns are intestinal overgrowth, fluid retention, and theoretical cancer risk from excessive cell proliferation, though that risk is very low. For retatrutide, early reports show similar GI effects as GLP-1, but possibly slightly higher heart rate and transient increases in liver enzymes, which are being closely monitored in trials. In terms of contraindications, GLP-1 and retatrutide share warnings for people with a history of medullary thyroid carcinoma or multiple endocrine neoplasia type 2. GLP-2 analogs have more caution in patients with intestinal malignancy. Alright, so mechanistically we've compared how they act, how they're dosed, how they affect appetite, gut function, energy expenditure, and side effects. But what does this mean in a practical sense? It means if your goal is blood sugar regulation or weight reduction, GLP-1 agonists or retatrutide are the focus. If your goal is intestinal repair or nutrient absorption, GLP-2 analogs are the key. Retatrutide could be seen as the evolution of GLP-1 therapy, not a replacement, but the next logical step in multi-pathway metabolic control. And that brings us to something really important, the future direction of these peptides. Let's look forward for a minute, because peptides like GLP-1, GLP-2, and retatrutide are not just part of a trend. They represent an entirely new frontier in how we approach metabolism, body composition, and gut health. If you look at where the research is going, it's clear that single pathway treatments are slowly giving way to multi-pathway solutions. That's why retatrutide is such a big deal. It's the first to combine GLP-1, GP, and glucagon receptor activation in one molecule. Researchers call this a polyagonist strategy, and the goal is simple: mimic the body's natural hormonal complexity rather than isolating one signal. Think of it like this. GLP-1 alone is like flipping one light switch in a room. Retatrutide flips 3 at once, illuminating the entire space. You get a more coordinated, more balanced metabolic effect. That's why in clinical data, people not only lose more weight, but also see improvements in fasting insulin, triglycerides, and even resting metabolic rate. Now, some people wonder whether retatrutide could replace GLP-1 therapies entirely. The answer is not yet, and maybe not ever. GLP-1 agonists have years of safety data, FDA approvals, and well-understood effects. Retatrutide is still in trials. It may eventually join or even surpass them, but GLP-1 drugs aren't going anywhere anytime soon. Let's zoom out a bit and compare the feel of these peptides in the body. People on GLP-1 agonists often describe a calm, gradual reduction in hunger, meals feel smaller, cravings fade, and energy becomes more stable. It's not stimulating. It's just quieter. With GLP-2, the feeling is different, more of a gut-level improvement. People describe less bloating, better digestion, fewer food sensitivities, and an overall sense of gastrointestinal comfort. That's because GLP-2's main job is to make the intestines more efficient and less inflamed. Retatrutide, on the other hand, seems to create a hybrid experience. The appetite suppression is profound, like GLP-1, but there's also a mild energetic lift, a subtle sense of higher metabolism. It's not a stimulant, but many report feeling more alert, possibly due to glucagon's thermogenic effect and the body's increased energy turnover. So when we compare these peptides holistically, each one supports a different piece of the metabolic puzzle. GLP-1 helps you regulate what you eat. GLP-2 helps you absorb what you eat. Retatrutide helps you burn what you eat. Now, let's look at how these peptides might fit into clinical or wellness frameworks in the future. For people with diabetes or prediabetes, GLP-1 agonists like semaglutide or dulaglutide will likely remain the first-line injectable peptides. They're effective, predictable, and well-tolerated once the body adjusts. For people with gut issues, inflammatory bowel disease, or malabsorption, GLP-2 analogs like teduglutide are life-changing. They actually restore gut architecture, something few drugs can do. And for people focused on obesity, metabolic syndrome, or aggressive weight reduction, Retatrutide could become the gold standard, assuming trials confirm long-term safety. But there's something else to keep in mind here. The human body was never designed to rely on one hormone alone. GLP-1, GLP-2, GIP, and glucagon all naturally fluctuate together after eating. What science is doing now is learning to recreate that balance in precise, therapeutic doses. That's why the future may not stop at retatrutide. Researchers are already exploring quadruple agonists that target GLP-1, GP, glucagon, and amylin receptors all at once. Each additional pathway offers a new layer of metabolic control, improving glucose handling, appetite, and fat oxidation simultaneously. Let's talk practical takeaways. If you're trying to understand which peptide makes sense for a given goal, here's the breakdown. If the goal is blood sugar control, GLP-1 agonists like semaglutide or liraglutide are ideal. If the goal is intestinal healing or improved absorption, GLP-2 analogs like teduglutide are the right fit. If the goal is aggressive weight loss with higher energy expenditure, retatrutide is the one to watch. If you were to visualize it on a triangle, GLP-1 sits at the corner for insulin and appetite, GLP-2 at the corner for gut structure and repair, and retatrutide at the corner for full metabolic activation. Another interesting aspect is how these peptides interact with exercise. GLP-1 agonists can make people feel slightly slower to digest meals before workouts, so timing nutrition becomes important. GLP-2 may actually enhance recovery by improving nutrient absorption post-training. Retatrutide's mild thermogenic boost could complement endurance or fat-burning workouts if calories are adequate. The combination of peptides and physical activity can yield powerful results, but again, only under medical supervision. These are not shortcuts. They're amplifiers of the work your body already wants to do. Let's also talk about tapering and discontinuation, because this is often overlooked. When someone stops GLP-1 therapy, appetite usually returns gradually over several weeks. Weight regain can occur if lifestyle habits haven't changed, not because of dependency, but because the hormonal signaling simply resets. GLP-2 analogs can cause mild rebound effects in gut motility when stopped abruptly. Retatrutide is still under investigation, but based on its long receptor activity, effects likely fade gradually after the last dose. The key is that peptides modify physiology while you're using them, not permanently. So long-term success still depends on nutrition, movement, and recovery habits that support those new metabolic baselines. Let's touch quickly on how these peptides are stored and reconstituted. Most come as lyophilized powders or pre-filled pens. GLP-1 drugs like semaglutide are typically in pre-filled auto-injectors or multi-dose pens. GLP-2 analogs like teduglutide often require reconstitution with sterile water. Retatrutide will likely be a pre-filled pen or vial system once released. All should be refrigerated, protected from light, and not shaken vigorously. Now, a quick point about off-label use. There's been a rise in compounded or research-grade GLP-1 and Retatrutide products being sold online. The concern isn't just purity, it's dosing accuracy. Because these peptides are active in microgram ranges, a small error can mean a big difference in response or side effects. Always use pharmaceutical-grade, medically prescribed sources, and never self-compound without laboratory verification. Mechanistically, all of these peptides demonstrate one central truth. Metabolism is not just about calories in versus calories out. It's about hormonal signaling, receptor sensitivity, and cellular efficiency. Peptides like GLP-1, GLP-2, and Retatrutide give us tools to fine-tune that system, but they work best when combined with healthy living. Let's sum this up simply. GLP-1 helps your body handle glucose and hunger. GLP-2 helps your body repair and absorb. Retatrutide helps your body optimize energy balance by working on all three major metabolic pathways. They're not competitors, they're complementary pieces of the same biological design. Before we close, let's quickly revisit dosing context. Semaglutide, 0.25 to 2.4 milligrams once weekly. Liraglutide, 0.6 to 3 milligrams once daily. Dulaglutide, 0.75 to 4.5 milligrams weekly. Teduglutide, 0.05 milligrams per kilogram daily. Retatrutide, currently studied from 1 to 12 milligrams weekly. All subcutaneous, all requiring titration, all dependent on individual tolerance and metabolic response. The biggest difference isn't just which receptor they hit, it's how many systems they influence simultaneously. Now, let's circle back to something important before we wrap up. These peptides are tools, incredibly powerful ones, but not replacements for balance. They don't override the need for proper nutrition, sleep, movement, or emotional health. They work with the body, not instead of it. They represent how far we've come in understanding biology, using targeted molecules to nudge the body back toward equilibrium rather than forcing it through blunt intervention. And that, truly, is the essence of modern peptide science. Disclaimer: the information in this episode is for educational purposes only and should not be interpreted as medical advice. Always consult with a licensed healthcare professional before beginning any peptide, supplement, or medication regimen. Thanks for listening, keep learning, and stay curious.